now we'll move on to detection of multi-drug resistant organisms. So detection and surveillance. So you may or may not be aware that we have the prestigious honor of being the first KPC ever identified in the United States, right here in North Carolina, or actually in the world, I think, correct? Definitely in the United States, perhaps the world. And it was back in 2001. We found that here in North Carolina. And since that time, KPC has actually been reported in all 50 states. So you can see here the green would indicate which states have found a particular carbapenemase, which this time we're talking about KPC, and they're all green now because it's been identified everywhere. But as we mentioned before, there are other types of carbapenemases, and you can see here the green states, the darker green states are where these other carbapenemase mechanisms have been identified. And North Carolina has now seen all of them. This is a bit old, but according to this older data, we hadn't seen OXA48 or VIM yet, but now we have collected them all, unfortunately. So what has North Carolina been doing as far as CRE surveillance? So as you know now, that's why we're having this webinar. CRE is now reportable across the state, and so, or at least carbapenemase producing CRE. But prior to that, back in March to September of 2016, we picked some sentinel surveillance sites, and then from November 2016 to June 2017, we accepted isolates but did not actively recruit further sites. And then from July 2017 to not quite the present, but August of this year, targeted recruitment for sentinel surveillance and special projects and outbreak response was occurring. So these are some results from our sentinel surveillance efforts. So as you can see here, we got about 9 isolates per month, and with a median of 6, and that was between January 2017 and August 2018. But the number of submissions grew over time, and I can't give you an exact number currently, but since we started requiring reporting of carbapenemase producing CRE, we've been getting about 5 or 6 a week, I would say, reports of CRE coming in. So obviously this is a growing problem, or at least it's our data collection is becoming more complete and recognizing a problem that was already large. And just over about half of the isolates test positive for carbapenemase production. So you can see here in this graph, the darker orange are the ones that were positive for carbapenemase production, and the orange hatch marks are the ones that were not found to have a carbapenemase. So about 57% of reported CRE were carbapenemase producing during that sentinel surveillance period. Since October 1st, that number is going down. I don't think, Heather, we have an exact number yet as far as a percentage of what it is now, but it's certainly lower. But definitely still have a concerning number of carbapenemase producers. And here in North Carolina, since we found KPC first, that is the most predominant carbapenemase that we identify here in North Carolina. And here that kind of gets down to it. So during the sentinel surveillance period of January 2017 to August 2018, of the CPCRE we identified, that was 103 during that time period. 76.7% of those were KPC. And then OXA48 comprised about 18.5%, and then IMP comprised about 4%, and then we just had a few NDM at less than 1%. And now I'm going to hand it over to Katie to talk about the AR Lab network and further response and containment efforts.
Thanks, James. So I'm going to first start by talking about this antibiotic resistance laboratory network, which is key to detecting colonization, especially for carbapenemase producing CRE, which is part of this containment effort that's a national focus. So the goal of the antibiotic resistance laboratory network is to detect the presence of carbapenemase producing organisms in order to intervene and stop the spread. If carbapenemase producing CRE is not detected, there's not usually people on contact precautions. You don't know what you have until you kind of look for it. So we know that colonized patients can be a transmission risk to the environment as well as other patients that may get infections. And that's why detection of colonized individuals is so important. The State Laboratory of Public Health plays an important role in detecting carbapenemase producing CRE and was funded by CDC as part of the antibiotic resistance laboratory network to characterize CRE. Specifically, the state lab was funded to perform antimicrobial susceptibility testing, or AST, to confirm the phenotypic detection of CRE in facilities. They've also received funding to use phenotypic methods to detect carbapenemase production. Specifically, they're validating the modified carbapenem inactivation method, or MSIM, which is the preferred method for detection of phenotypic carbapenemase production. Additionally, the state lab performs molecular detection by PCR, and the most routine tests that they are conducting are for the carbapenemases KPC, NDM, and OXA48, but they are also validating and preparing to onboard the detection for VIM, IMP, as well as MCR1. The Antibiotic Resistance Laboratory Network also includes 7 regional labs across the United States, which is shown here on the map as white dots. These labs were funded by CDC for a variety of projects, one of which is to rapidly detect colonization with carbapenemase-producing CRE through colonization screening. These resources are available to facilities in consultation with local and state public health departments free of charge, and we'll go through this process a little bit later. Additions were made to the Reportable Diseases and Conditions list to reflect national priorities. The Council of State and Territorial Epidemiologists, or CSTE, passed a position statement to make carbapenemase-producing CRE nationally notifiable. And so to support this position statement, we made some additions to this law, and these additions became effective starting October 1st, 2018. Additions include CRE and C. auris. C. auris is an emerging drug-resistant yeast that has been associated with outbreaks in healthcare settings, but we're focusing on CRE today. So reporting of these organisms is required within 24 hours of detection, and we expect that reporting will facilitate the early detection, rapid response, and containment of these organisms, prevent additional transmission, as well as provide data to develop and implement prevention and control measures. Reporters should report the following to public health: identification of CRE from a clinical specimen associated with either infection or colonization, and all antibiotic susceptibility results, if they're available, and all phenotypic or molecular test results, if testing was conducted and results are available. We will describe and break this down further in the next slides. Because CRE can be many different organisms, we have limited reporting to be only 3 main types of bacteria, sometimes called the big 3 of CRE. This is also in line with what will be nationally notifiable. For the purposes of reporting in North Carolina, CRE are defined as Enterobacter species, E. coli, or Klebsiella species that are positive for a known carbapenemase resistance mechanism or positive on a phenotypic test for carbapenemase production, or those species that are resistant to any carbapenem in the absence of the carbapenemase resistance mechanism testing or the phenotypic testing for carbapenemase production. So let's break down this reporting case definition and focus on the types of bacteria you'll be looking to report and where to find this information. Some of your facilities may perform their own testing, or some of your facilities may send specimens to a reference lab. Either way, it's important to know where to find certain information on lab reports or in the EMR. Some of your facilities may have flags built into your EMR to flag a lab as CRE for review. Since that may not be the case everywhere, I'm going to review the basics in these next slides. For those of you with flags, I would recommend you review the logic to make sure that they use the most recent CRE case definition from CDC. We also put together an extensive laboratory guide with assistance and guidance from the state laboratory as well as clinical laboratorians at major medical centers across the state to help guide laboratories as they look to implement reporting of CRE. I'll also emphasize that while all CRE warrant infection prevention action, not all CRE are reportable. So that's important to differentiate there. So you know what bacteria you're looking for. Where do you look for it? One of the first steps is to look at the lab report for any bacteria that were identified in the specimen. To identify bacteria, labs may use culture, where they try to grow the bacteria out of the specimen, or they may use other methods called NAT, or nucleic acid amplification test, or PCR, to identify the bacteria based on the genetic material that is present in the specimen. An example lab report is on the right, and I have boxed in red the type of testing that was done and the organism ID. So for this example, a urine culture was performed and the lab isolated Enterobacter cloacae from the specimen. This lab also provided an estimate as to the amount of Enterobacter present in the specimen. It's important to note that for the amount of bacteria in the specimen, that doesn't matter when it comes to reporting CRE. And especially IPs, we know you might be familiar with looking at the counts of bacteria in a specimen for reporting into NHSN, but for reporting CRE, the amount of bacteria does not matter. Going back to our reporting case definition, let's focus on what you will probably see most often, which is a lab report that has only antibiotic susceptibility results. That is, carbapenemase resistance mechanism testing or phenotypic testing for carbapenemase production has not been conducted. So the reporting case definition defines CRE as those three main types of bacteria we discussed that are resistant to any carbapenem. So that's one or more carbapenems. But CRE are identified by their resistance to the carbapenem antibiotics. The next piece you will have to review on the lab report is the susceptibility results. These are the results from testing whether or not certain antibiotics are effective at treating the bacteria. These may appear on the lab result as MICs, which stand for minimum inhibitory concentration, with interps or interpretations. While MICs are numbers, the interpretations tell what the numbers mean. Look for these interpretations on lab reports. An S stands for susceptible, which means the listed drug can be used to treat the organism. I, or intermediate, means the listed drug may not be effective treatment for the organism. And R means resistant. The listed drug cannot be used to treat the organism. For identifying CRE, you want to look for Rs next to the carbapenem antibiotics: doripenem, ertapenem, imipenem, and meropenem. Ertapenem and meropenem are often included on susceptibility testing panels. Going back to our reporting case definition, let's look at that first criterion that talks about being positive for a known carbapenemase resistance mechanism, or that's positive on a phenotypic test for carbapenemase production. You may not see these as often, but it is important to understand these results when you do see them, as a positive result for either of these types of tests means the CRE is a carbapenemase producing CRE, or CP-CRE, which we talked about earlier. There are two types of tests that are used to detect CP-CRE. Phenotypic tests detect if the bacteria is producing the carbapenemase enzyme that is able to break down carbapenem antibiotics. Type of phenotypic tests include carba-NP, metallo-beta-lactamase testing, for example, the E-test, modified carbapenem inactivation method, or MSIM, the carbapenem inactivation method, or SIM, as well as modified Hodge test, or MHT. The other type of test used to detect CP-CRE is called a molecular test. These tests detect if the bacteria has the genetic material that would allow it to produce a carbapenemase. This type of testing is also called resistance mechanism testing. Types of molecular tests include PCR, as well as the GeneXpert Carba-R test. These methods can detect the specific type of carbapenemase resistance mechanism that the bacteria has, and we've listed them in parentheses next to those tests. This is an example of a lab result for a molecular test for CP-CRE. I've boxed in red the name of the test, which for this example is the Cepheid GeneXpert Carba-R assay, and also the result. The result shows that the KPC carbapenemase resistance mechanism was detected. All right, so now we're going to go through and just kind of do a knowledge check, and we're going to see if you're able to identify what is CRE. So here's an example lab result. And I have blown it up here so you can get a better look at those susceptibility results, which you need to identify. So again, the first thing we're going to look at is the organism, and we're going to look for the susceptibility results. And I've included a hint here that the carbapenem antibiotics are doripenem, imipenem, ertapenem, and meropenem. So just give everybody a couple seconds here, just formulate your answer in your mind. So I've highlighted here the organism and the susceptibility results that are pertinent. So the organism is Enterobacter cloacae, and the susceptibility result that is pertinent is that it's resistant to ertapenem. So is this a CRE? Yes, this is a CRE. So Enterobacter is a type of Enterobacteriaceae, and it's resistant to ertapenem. So it's a CRE, and this would also be reportable because it is an Enterobacter species. Okay, so here's another example of a lab result that you might see. I've tried to zoom in here so you can see those results a little bit better. Again, we're going to look for the organism identification as well as the susceptibility testing results. So take a couple seconds there to formulate what you think the answer is. So I've highlighted here now the organism is Klebsiella pneumoniae, and the carbapenems that were tested in this panel were ertapenem and imipenem, and it was susceptible to both of those. So is this a CRE? It is not. It is not a CRE. It is an Enterobacteriaceae because it's a Klebsiella pneumoniae, but it is susceptible to the carbapenems that were tested. So it's not a CRE, and therefore also not reportable. So the next question that you might have in your mind is, the state lab has these resources available for testing. When should your facility consider sending isolates to the state lab for this additional testing? If your lab does not conduct phenotypic or molecular testing for carbapenemase, you should send some of the isolates that are on this slide. So Enterobacter species, E. coli, or Klebsiella species that are resistant to any carbapenem. If your lab is not doing that additional testing, the lab would accept other genera of Enterobacteriaceae, but just know that these are not reportable. We especially want you to focus on the CRE that are reportable. If your lab is performing molecular testing and a carbapenemase other than KPC is detected, we would request that you send the isolate for confirmatory testing. Another case to consider isolate submission that's not on this slide, but we wanted to bring up here, is that if your lab is performing a phenotypic test other than the MSIM, the modified carbapenem inactivation method, such as the MHT or carba-NP, we request that you send the isolate regardless of phenotypic results so that carbapenemase can be identified. Please note that the modified Hodge test, or MHT, is not a recommended test for carbapenemase detection because of its limitations. More info on this can be found in the laboratory guide that I mentioned earlier. So essentially what this recommendation means is that you should send any isolates that are MSIM positive, so they're phenotypic positive for carbapenemase production, send those so that the state lab can characterize what carbapenemase is present. And if your lab is using modified Hodge test or carba-NP, send those isolates regardless of the phenotypic results. And as far as how to report, it's going to look very similar for other communicable diseases and conditions. We will be able to have the capability to accept reports by ELR, and you should also, if you're using fax or phone to the local health department, continue to do so for CRE and Candida auris. The local health department, once they receive that case report, will capture case information in the SurveyMonkey case report form until our NCEDS module is live. So when a case of CRE is reported, the local health department will conduct follow-up and ask certain questions about the case. This will include questions that will inform the public health response, like what other healthcare facility exposures did this person have, which can get at the risk of interfacility transmission. Did the individual have international travel or international health care, which gets at, was there a risk for carbapenemase producing CRE acquisition while they were receiving care in those other countries? Were there any medical devices in place within 2 days prior to culture, which again gets at the risk for acquisition of CRE for that case, as well as risk of transmission to others? And is the person receiving wound care? Again, getting at the question of, is there a risk for transmission to others? And so at that, I'm going to turn it over to my colleague, Heather Dubendris, who will talk about containment strategies for CRE.
Good afternoon, everyone. So I know that was a lot of information leading up to this point in the presentation, talking about historical surveillance and detection, as well as helping you guys determine how to identify and report CRE to us. Now we're going to move into the rapid response and containment. And so we'll walk through some of the strategies that we employ here at the Division of Public Health to ensure that there's a systematic response happening. And unlike some other communicable diseases with CRE, what's unique about MDROs is that we have a systematic response to even a single case to assure that we're slowing or containing the spread of that resistance. So we'll walk through what that systematic approach looks like, including the infection prevention assessments, the importance of interfacility communication, among other components. So the goal of any investigation, containment, or response activity, as I stated, is to really to contain or slow the spread of drug resistance. And so when we talk about a CRE case investigation, there are several main components that won't change regardless of the setting or the mechanism of resistance. So firstly, we want to make sure we're appropriately characterizing the organism, which Katie just walked through. So part of that includes making sure we understand which mechanism of resistance and the local epidemiology of that mechanism. And so that's where the state health department can come into play. Both with assistance with characterizing and also helping understand the epidemiologic data related to that mechanism. The next step is to identify if transmission is occurring. And if transmission is occurring, identify any affected patients or residents. And lastly, just with all communicable disease responses, we want to ensure that appropriate control measures are occurring promptly as soon as we have identified the case to assure that we halt transmission. So there are lots of types of responses, and these responses will vary, as I said, based on the organism and the mechanism of resistance, as well as the setting. So a response in an acute care hospital will look different than a response in a long-term acute care hospital or a skilled nursing facility. And lastly, we're asking our local health departments to prioritize based on those first two and their available resources. And so we're working with our local health departments to help with those prioritization activities. Just like with an outbreak investigation, we want to make sure that each investigation happens in a standardized manner. So the first step is to ensure that your case meets the case definition. So looking at those case definitions and looking at the lab results to make sure what you really have is a CRE. I think especially with CRE, sometimes this is easier said than done. Sometimes you'll see a lab result that just says possible carbapenemase producer, and you'll have to work with your laboratory to understand what that means and what testing was performed. But we want to make sure that we're meeting our case definition before we get too far into our response. Next, you want to notify the patient and any other healthcare facilities as appropriate. So CRE is not something that happens just within four walls. We know that drug resistance spreads regionally, and so it's really important that any other healthcare facilities that have had contact with this patient are aware so that we can help facilitate containment strategies at all of the facilities that have come in contact with a CRE case. And that includes the implementation of appropriate control measures, which I'll go through in some of these later slides, as well as looking at the patient's risk factor information. Some of those questions that Katie mentioned, the local health department will be calling about, certainly pertain to the patient's risk factors, both for acquiring and for transmitting CRE. And we're going to conduct a healthcare investigation as part of that response. So both locating the healthcare facilities that may be at risk for CRE transmission, as well as assessing infection prevention activities in those settings. A contact investigation may be initiated, and then, as always, we want to maintain prospective surveillance, so we want to keep an eye out for additional cases. So that's regardless of the setting. So one of those measures that I talked about was making sure appropriate control measures are implemented. And for CRE in the acute care setting, what that looks like is contact precaution. So if you look at the CDC's 2015 CRE toolkit, they mentioned that in acute care settings, for CRE, regardless of whether it's a carbapenemase producer or not, most acute care settings should implement contact precautions for any known case of CRE. So that includes gowning and gloving for all patient interaction. And there's currently not a public health recommendation for when to discontinue those contact precautions, because we know that once someone is diagnosed with CRE, colonization can be prolonged. It also includes hand hygiene. So we know that organisms like CRE are most often spread through healthcare worker hands. So I always like to remind folks that if it's been a while since you've had a hand hygiene in service, a new case of CRE is a great time to go ahead and do that in-service education to maintain heightened awareness about the importance of appropriate hand hygiene across your different types of staff, including your environmental service folks, to make sure that they are aware of what it means when somebody is on contact precautions and that they're performing appropriate hand hygiene. And then this last figure here just talks about reducing opportunities for transmission. So trying to think through how you're scheduling various procedures or activities with this patient. This becomes particularly important in the long-term care setting where we're possibly looking at scheduling physical therapy or things like that. And we recommend just trying to schedule those activities so that we're reducing the opportunities to transmit to other residents. So scheduling things for the end of the day when possible, so that we can have any reusable objects terminally cleaned before the next patient is exposed to them. When we talk about environmental cleaning, you can use any EPA approved disinfectant. It's not like C. diff where we need to have bleach, but you just want to make sure you're using appropriate cleaning products and that you're cleaning surfaces frequently. So this image here looks at some of those high touch surfaces in patient rooms. And for a CRE patient, we definitely recommend frequent cleaning, especially of those high touch areas. So the bed rail, the bed tray, the sink, faucets, any of those common places that you're used to seeing. And we recommend when possible that these rooms are cleaned last. The other control measure that I want to highlight here today is about interfacility communication. So as I said before, CRE is not occurring in a vacuum in your facility. And because of the nature of the risk factors for CRE, often these patients are highly vulnerable with frequent healthcare exposures. And so often these are patients that have exposure to other healthcare facilities, whether they're coming to you from a skilled nursing facility or a rehab facility. Even if they came as an outpatient, they may be visiting a wound care clinic. And so it's really important to make sure that we're facilitating that communication in a streamlined way so that all facilities are aware of the CRE results so that appropriate precautions can be put in place. And those appropriate precautions will look different based on the setting, but as long as we give them that information about the MDRO status, that facility can make that assessment upon admission to prevent opportunity of transmission to their patients or residents. And so what's shown here is an interfacility transfer form that my colleague Katie developed during a CRE outbreak, actually. And so this is a form that's available on our webpage, and it was developed in close consultation with a lot of different partners. So we actually went to community meetings at the hospital and talked with hospital staff, skilled nursing facility staff, ED staff, emergency transportation services, and figured out what an acceptable form would look like, what pieces of information they wanted to make sure were included in addition to those key infection prevention measures. And so this has been piloted in the community and is very successful. One of the things that I like about this is you can pre-fill the PDF form and save it, so it makes transferring easier. And it also prints in triplicate. So if you print it out on the computer, you can print out a copy for yourself, for transport services, and also for the receiving facility. So that's just one resource to help facilitate that communication. This is another way of looking at some of those response elements. So this is from CDC's interim guidelines for the control of multi-drug resistant organisms. And CDC looks at multi-drug resistant organisms in 3 tiers. So tier 1 being something that is truly novel or truly pan-resistant to all antibiotics. And so that's going to be the most aggressive response. That's truly a containment opportunity. And tier 2 also represents a containment opportunity. So this is a mechanism or organism that's not routinely found in the region, but has been found in the United States. And so you can see that that is still a containment response, but some of those more aggressive elements are not routinely recommended. And then tier 3 are those organisms or mechanisms that we're considering regularly found, but not yet endemic. And so in North Carolina, we currently consider KPC a tier 3 mechanism, and any other carbapenemase producer at this time would be considered a tier 2. And so what that means for us is that we're regularly recommending infection control assessments, laboratory surveillance, both prospective and retrospective, at a minimum screening of healthcare roommates. And then we do a tiered approach for screening recommendations. So based on those findings through the infection control assessment, the laboratory surveillance, and that initial healthcare roommate screening, broader screening of healthcare contacts may be recommended. But you'll see here that we're not regularly recommending household contact screening or environmental sampling or healthcare personnel screening in these instances. And the reason we don't recommend screening of healthcare personnel is because there's not any sort of decolonization that can occur. So by improving your infection prevention measures, any transmission should be able to be prevented. It's not necessary to screen your staff. So just to elaborate a little more on that contact investigation component, so I think Katie alluded to this earlier, but the Division of Public Health does have the resources to help screen any roommates or high-risk contacts that are epidemiologically linked to a carbapenemase-producing organism, and that can be done free of charge at your facility through our resources. So we are able to provide materials for shipping and conduct that testing for you. And that's always done in consultation. So if you get a result back, or if you hear from us, then we'll discuss it at that time. Or if you have a result that is a carbapenemase producer, when you report it, then we'll arrange that screening as necessary. So the screening process looks something like this. So the initial request will come through, and we really rely heavily on your infection prevention expertise at your facility when we're conducting the risk assessment for broader screening. And so this is something that's done in consultation with DPH, but it's not a decision that's made in a vacuum. This is a decision that would be made between your facility and the health department based on the information that you have. So once that request is made, we would provide any swabs, any educational materials or resources on how to appropriately collect that swab, as well as shipping instructions. And then we would arrange to have the local health department go out on site to provide those swabs to you. The local health department isn't collecting the swabs, but they're just there to help facilitate and answer any questions. So you provide the information shown here to them so that they could get a line list sent off and let us know which patients we're expecting results on. And then the facility would conduct the swabbing. Then we would work with the health department to pack it up and arrange a FedEx pickup. And results are usually available within 48 hours. So those swabs would go off to our regional lab in Maryland, and the local health department would be in touch with you for the results. And how involved the local health department is in this process is dependent on your facility and your resources. So again, this is all done in collaboration. This is an example of what one of those swab collection kits would look like. When you get it, it would all be in that specimen bag, which comes with absorbent material as well as collection instructions. And what's really great about these collection instructions is it actually has pictures about what an acceptable amount of specimen to get on that swab is. So these are rectal swabs. And so the pictures shown there show the biggest problem we have is getting too much stool on the swab, and then the test isn't able to run efficiently. And then it comes with the swab as well. And then this is just a closer look at the swab, and I won't go through these directions here, but this briefly just outlines for you what that swabbing process looks like. And then we will also provide guidance for packaging and shipping, and we'll, before swabbing occurs, determine with you whether you'll be shipping this back through our prepaid FedEx account or whether the local health department will be arranging that shipment. So for any of this response to occur, we really need to make sure that we're relying heavily on partners. And I hope that walking through some of those steps started to highlight that for you. I just want to highlight a few of our partners here. So we rely heavily on CDC and their antibiotic resistance laboratory network to conduct the screening, as well as to provide the funding for our state lab to do that mechanism testing. Our state laboratory of public health arranges all the shipments of our swabs and conducts all of the isolate testing for us in the state. We sometimes work with our sister agency, the Division of Health Services Regulation, particularly in long-term care facilities. As evidenced by the presentation here today, we rely heavily on our colleagues at SPICE. The local health departments are heavily involved, and of course, all of this work is done with an immense amount of effort from our facilities like all of you. So I just wanted to take a moment and make sure that we stated how much we appreciate all of these partnerships and how important partnership truly is for containment here in North Carolina. This is the last slide on partnership that I think really just pulls together some of these messages for today, how important it is for us to work together and to communicate. So this is some modeling that CDC put out in a vital signs report a few years ago. And this modeling is predicting, they're imagining that there are 10 facilities in an area that regularly share patients through admissions and discharges, both directly and indirectly. And in that first sort of gray or silver bar, that's the status quo. So if we all keep doing what we're doing, so some facilities are being really proactive with their prevention of multi-drug resistant organisms. Some facilities maybe don't even know what CRE is, and so they're not putting patients on precautions. They're not doing any sort of active screening. At the end of a 5-year period, this modeling predicts that 2,000 patients would get CRE in this community. The next bar shows a little bit of a better story. So this shows independent efforts for that same time period. All of those 10 facilities that share patients begin actively working to prevent the transmission of multi-drug resistant organisms. And in this middle bar, we see that 500 fewer patients get CRE in the community, which is certainly impressive. But what I think really drives our point home is that last bar, which shows a coordinated approach. And so by a coordinated approach, we mean that we're communicating information effectively between organizations. When we do have a CRE result, we're also working with your state health department so that we can keep track of, on a broader scale, what's happening, and we can perform outreach and education as needed. And in that same 5-year period, we're able to get the number of new CRE cases down to just 2% of the patients in that population, or only 400 new cases of CRE. I'm not going to spend a lot of time here, but this is just some general prevention measures that you can find more details on in the CRE toolkit that I mentioned previously that's linked at the end, what your facility can do to help prevent transmission of multi-drug resistant organisms. And you'll see that many of these steps are similar to what we're organizing when we talk about a CRE response. The importance of communicating with your laboratory, I can't stress enough. So making sure you understand what methods are being conducted at your microbiology laboratory for CRE identification, whether or not they're doing any sort of carbapenemase testing. Performing periodic reviews of that lab data so that if something changes, if there's a trend that's changing, you're able to detect that and reach out if you need additional resources or just to talk it through with somebody. We're always here to discuss. And then the last recommendation is something that has been in place since 2013, but we now have resources to help facilitate if anyone is interested in trying to implement this. But CDC does recommend considering admission screening to detect colonization for any patient that's been hospitalized outside the United States in the past 6 months. And that's because many of these mechanisms of resistance that we don't routinely see here in North Carolina are much more common in other parts of the globe. I want to pause briefly if there are any overarching questions. The last portion of our presentation today really we hope will truly help put all this together for you. We have an exercise where we're going to walk through a CRE response from identification through that follow-up. So hopefully if you have questions, they'll be answered then, but I know this is an extraordinary amount of information to try to fit into an hour. So we just wanted to pause briefly before I hand it over to Jennifer McFarquhar. And not seeing any immediately, I think in the interest of time, we'll just keep moving, but we will save time for questions at the end.
All right, thanks Heather and the rest of the team. So my name is Jennifer McFarquhar, and I think we will go ahead and move forward with the tabletop exercise. Again, as Heather mentioned, I hope this is able to kind of bring together some of the information that has been reviewed today. So and at the end of it, you might have a kind of a clearer picture of what we are doing here at the state for CRE detection, surveillance, containment, and response, and how we all can engage together in that process to minimize the risk of transmission. So part one of the exercise, notification. Of course, this always occurs at 4 p.m. on a Friday. So here's the scenario. On March 6, 2018, when reviewing your microbiology laboratory results for routine surveillance at Acute Care Hospital A, you identify a 63-year-old male patient, Mr. Z, with a Klebsiella oxytosa isolate from a wound culture taken on March 2nd. The isolate is resistant to ertapenem. So, is this reportable to the North Carolina Division of Public Health? So this is another opportunity for you to respond. So if you have not already done so, please go to pollev.com, SPICE, and so you have the option, you have 4 different options here. So the results are coming in. So let's see. Looks like we've got 1 or 2 for A, majority of people for B, a couple of people for C, and no one for D. So let's see what the correct answer is. Oop, does it go through? Oh, no. There we go. So we will show the correct answer, but it is B. So about 84% of you were correct. So yes, that result should be reported. So if you want to review it real quick, that was a Klebsiella oxytosa, and it was resistant to ertapenem. So yes, that is reportable, and the isolate should be forwarded to the state laboratory. So continuing on with that. You report the case of CRE to your local health department, and the isolate is forwarded to the state laboratory for resistance mechanism testing. On March 9th, the health department calls to let you know the state lab results are in. We work fast around here. The isolate tests positive for Verona integron encoded metallobeta-lactamase, or VIM, V-I-M. VIM is a plasmid-mediated carbapenemase that is rare in the United States. This is the first VIM-producing CRE for the hospital and for the region. So, opportunity for poll again. So you have a couple of options available to you. So let's see.
Click it again.
Wow, it looks like 100% of you have answered already?
No, just
Oh,
that
okay.
100% of the
Okay.
answers are.
Gotcha. There we go. Okay. So I'll give it a few minutes here. Okay. Oh, it's not letting me pick more than one. Okay. All right. Sorry about that. Okay. How do we show the correct answer?
In this, when there's more than one, I don't think there
Gotcha.
is.
Okay. All right. So it was a choose all that apply, and I apologize. I think it's only allowing you to choose one option. So the isolate is a carbapenemase producing CRE. It's a CPCRE. So that is correct. And based on this, it's not only a CRE, but it is a CPCRE. And so additional case investigation is warranted. and also additional public health action is warranted. So all of these are correct.
It's an open-ended.
Okay. So what should your facility do to prevent transmission?
This is Heather, and you can maybe think back to that slide that I showed briefly at the end of my session for some of the things that you can do to help prevent CRE transmission.
There we go. So the results are starting to come in. This is kind of like a word cloud. So in order to prevent transmission from occurring, so very good. So far we're seeing hand hygiene, contact precautions, giving one-to-one care.
Yes, I'm so
Yep.
happy to see somebody put communication and environmental cleaning.
Exactly. I was like, wait a minute, we should highlight that. Hand hygiene in service. Exactly. Yeah, very good. We're seeing a lot of, the appropriate precautions to take. So, which includes definitely assuring that the patient is on contact precautions. I saw a one-to-one care in there, definitely making sure that, the healthcare providers are using hand hygiene appropriately, are not sharing equipment between patients, definitely to minimize the risk of transmission to other patients. I see dedicated equipment as well. That's correct. High touch surface cleaning. So somebody was listening there. So yeah, conduct an investigation, identify who has had contact with the individual, isolate the individual. Environmental cleaning, very good. And as Heather stated, somebody had put in here communication.
Call the health department.
That's right. Notify transferring facility.
Someone was ready to do a colonization screen as well, I
That's
saw.
what it looks like. So yeah, all of these are correct. So yeah, very good. All right. Private room, that's one thing that we haven't seen before here, but that's exactly right. We would recommend a private room if possible. Scheduling optimization. That's exactly right. So you want to make sure that, if the patient does need some sort of therapy that, and they cannot conduct the therapy in the room, that you would perhaps schedule that person as the last last appointment of the day in a different location. Yeah, procedures at the end of the day. That's exactly right. Terminal cleaning of equipment. And then flagging the chart if you have that capability, as Katie mentioned, with the electronic medical record. Sometimes you actually have the ability to flag the chart. Other times you don't. So it looks like the responses are slowing down, and I'll have to say that these have been excellent responses. I don't know that I have anything else to add. I'm going to look at my team members to see if they do.
The only other thing would be on the next slide would say stewardship, which is more of a long-term intervention.
Yeah, exactly. So, so I guess just to kind of summarize what you all said. So obviously conducting staff education, I saw just in time in service, laboratory notification, communication, period, cohorting if possible. I saw the one-to-one care, and I guess I was kind of in my mind considering that to be cohorting of residents and staff as well. Contact precautions, hand hygiene, we saw a lot of those responses. Definitely attention to environmental cleaning and particular the high touch surfaces. Again, communication, reviewing infection prevention policies and procedures. I don't know that I specifically saw that stated, but I think that would be within the scope of response in this circumstance. And then as Dr. Lewis just stated as well, antimicrobial stewardship. But that would come, I think, a little bit later in the response. So let's move on. So what are some key questions to ask to begin planning your containment strategy? thinking. Yeah, okay.
So I can kick us off with one of my questions while people are thinking. So one of the things that I would want to know are about the risk factors for the individual.
That's right. Any recent travel history, and that's exactly what Heather was alluding to. And then somebody is moving ahead to screening. So somebody's already thinking down the line as far as screening and what the current policy is. I'm not sure if that's related to infection prevention or about the screening policy, but definitely there's some travel. Where was the patient from? Interfacility communication, interfacility transfer. Looks like other risk factors would include central lines or other lines and wounds as well. And I like that somebody's thinking about the steps of an outbreak investigation, confirming the organism, because we definitely want to confirm that diagnosis. Patient risk factors, what type of unit the patient is on, and who has already had contact with a patient, and do you restrict healthcare workers? So I think we would cohort definitely. If there's concern of transmission, you would want to make sure that you do cohort patients with similar resistant organisms, and then cohort the staff members who are caring for those patients as well. And let's see, is transmission occurring? That's exactly right. We want to see if transmission is occurring, and so one of the previous responses was actually to look at screening, and so we'll move on to that as well. And control methods. Anything else you all have to add?
I think that's great.
Yeah. All right. So a couple of key points to remember here. Within healthcare settings, Klebsiella bacteria are primarily spread through person-to-person contact. Again, we've definitely mentioned and emphasized the importance of hand hygiene, of careful environmental cleaning, and of implementation of contact precautions. And what we are dealing with here, just to remind us, we're dealing with a VIM, which is a novel CRE mechanism. And so we definitely want to contain that. We don't want that organism to spread any further. So just some items to consider. And did you put these as questions?
One of them was the first one.
Okay.
We already discussed the second one.
Okay. All right. So let's see. I think just some items for consideration as well. Where would you go for additional information to plan your response? So do you have resources that you would look to? Let me see if there's a question. No. Okay. So who would you go to for additional information to plan your response? We mentioned the local health department already. The local health department is a good response. And then, of course, we at the Division of Public Health are available for consultation as well. Anyone else in the room have anything to add?
Our SPICE colleagues, for sure. There's that nice Ask SPICE feature on the website.
That's right.
And then just knowing your general resources. So there's a lot of great CDC toolkits available. I think APIC has some information as well. So just gathering your resources and also figuring out who on your team is going to be able to assist you. Sometimes these investigations can take quite a bit of time. So making sure that you have your force multipliers ready to go. So if there are other infection preventionists at your facility that can assist.
And if you're part of a large hospital group, or if you have a good relationship with another hospital, getting in touch with their infection prevention teams to see if they've dealt with this in the past, that can be a good resource as well.
Yeah, so all very good options. So a lot of resources are available to you, and definitely don't be afraid to reach out. And we've actually already discussed the second point, so I'm going to move on in the interest of time. So part 2, so here is the case history. So it looks like for the entire month of January, this individual was in Hospital X in Athens, Greece. So on January 1, while on vacation in Greece, Mr. Z suffered a stroke. He was hospitalized in Athens in an intensive care unit. During his stay, he developed a sacral decubitus ulcer. As part of treatment, Mr. Z received several courses of antibiotics. On January 31, Mr. Z was discharged and flew home, presumably to the United States, with family. So continued. Hospital A in the United States. After landing in the U.S., his family brought him directly to the emergency room at Hospital A, and he was admitted. The decubitus ulcer showed no sign of infection, but Mr. Z remained bedbound. He was continent of stool, but required assistance with activities of daily living. Mr. Z had no roommates during his stay, and he was not on contact precautions. So moving on, February. So February 1 through 28, Nursing Home 1, again in the US. Late on February 1st, Mr. Z was transferred to Nursing Home A. He was admitted to a double occupancy room with roommate Y. Mr. Z still was not on contact precautions. On February 23rd, Mr. Z's wound began to look worse and he developed a fever. He was empirically started on antibiotics. His fever continued and he developed diarrhea. Continuing on to March 1 through 4, Hospital A. On March 1st, Mr. Z was readmitted to the hospital, and on March 2nd, Mr. Z's physician ordered for the decubitus ulcer to be cultured. On March 4th, the CRE result was reported from the clinical laboratory, and Mr. Z was placed on contact precautions. So, what risk factors did the patient have for CPCRE? All right. Looks like most of the responses are in now. So the correct answer is C, international, hospitalizations, recent use of antibiotics, and an open wound. So very good. 96% of you all responded correctly. Why might the health department call you about the CPCRE result? We have a lot of fast responders here. I like it.
And if you click there on show results, it'll show you how many.
Okay. All right, so I think everyone was correct here. So option B is correct. You want to notify the facility where the case had recent health care as part of the public health response. Again, because that regional prevention measures are the key to control. And again, Heather spoke to that very well. Okay, one item to consider. Based on patient's case history, how would you evaluate potential for transmission and what might be the key next steps for Hospital A? Okay, this one might be a word cloud. That would be good. Let's see. I like it.
Somebody thinks transmission is likely.
Right.
What are some key
Okay.
next steps?
I think evaluating the possibility of transmission. Okay, good. It looks like good. More responses are coming in now.
Investigation.
Investigation, right? Communication, which I like to see. Surveillance. Communication is coming up very nicely.
I think it's jumbling the responses a little bit.
Because there were two questions.
Yeah, exactly. Yeah. So definitely we want to evaluate the possibility of transmission. Because the patient was not on contact precautions, and the patient did also have a roommate, especially at the nursing home. So there are a couple of next steps that we would want to identify. So do we go over the next steps? No, okay. So some of the next steps would definitely be communication, reaching out to partners, and seeing who may have been exposed, and then also screening. So we definitely would want to look at those patients who were at high risk of coming into contact with this individual while he was not on contact precautions.
One of the ways that you would determine who is at high risk, one of the key next steps for the hospital may include doing some infection prevention observations.
Yeah, and that's always key whenever you think transmission might have occurred, and kind of observing, what did hand hygiene look like, and what are some of the other risk factors. The patient obviously had a wound, and so, observing wound care and observing wound care practices would be something else that you would be very interested in. Okay, all right, so moving on. Part 3, facility assessment. After a site visit performed at your hospital in conjunction with the health department, you find multiple issues, including poor adherence to hand hygiene, patient care equipment stored around inpatient room sinks, and improper application and removal of personal protective equipment. So which of the following are risk factors for CPCRE transmission? And
Again, it's probably just.
okay. Yeah, and it's a choose all that apply, but it might only allow you to choose one. So the responses are still coming in, but since it's not allowing you to choose all that apply, we'll go ahead and go through. So definitely a risk factor. All of these would be considered risk factors for a transmission of CPCRE. All right, so in the interest of time, we'll go ahead and move forward, but all of these answers are correct. So several infection prevention issues were identified at Hospital A. How would you immediately address the infection prevention concerns? Number 1, and then number 2, identify if transmission has occurred. So I know we've talked a little bit about immediately addressing the infection prevention concerns, and those were some of the responses that came through before when you all were talking about just in time in services for hand hygiene, but also, re-education around hand hygiene, but also the application, the donning and doffing of personal protective equipment, and then, making sure that environmental services is cleaning the room appropriately. And then the second question here, identify if transmission has occurred. And again, this has been mentioned before, but screening, so screening of roommates or other high-risk individuals, and we talked about this with some of the infection prevention observations, so identifying those individuals that may have been exposed to healthcare providers who were not using good infection prevention practices, possibly during wound care, for example.
And sometimes we will do screening just based on them being on the same floor, depending on what tier the organism is that we're dealing with. We may expand screening.
Exactly, but this is VIM, and so we definitely would want to screen. All right, so part 4, screening. So on March 9th, in consultation with the health department, your facility screens 5 hospital patients who overlapped with Mr. Z's current hospital admission in the same unit for 3 or more days before he was placed on contact precautions. And Mr. Y, Mr. Z's roommate at long-term care facility 1, who's been transferred to your hospital with pneumonia. So just to remember, we can assist you with coordinating the colonization screening. I think it was both Katie, it was Katie who actually talked about the screening in particular through the Regional Antimicrobial Resistant Laboratory Network, or ARLN. So what other options would we want to consider here? What data do you want to collect on those people whom you screen? What sites are appropriate for CRE screening? And then how will those swabs be acquired? Do we have any? So just a couple of things to consider. So what data would you want to collect on those individuals whom you screen? Some demographic information, right? And perhaps how that person might be considered high risk.
So
Anything
just
else?
a basic line list, and that's something that when we send you the swabs and materials, we can provide you with a template.
So what sites are appropriate for CRE screening? And I think, Heather, you actually talked about this with your response and containment strategy. And this is actually a rectal swab. So it's a rectal swab. And again, that comes in a very nice baggie with very clear instructions on how to collect that swab and how much is appropriate to obtain on that swab. And we will help to facilitate the acquisition of those swabs. All right, so part 4, screening. On March 11th, 2018, screening identifies one colonized case of VIM. Okay. So after all that, we had transmission somewhere, and there were plenty of infection prevention breaches to explain that. So part 5, the conclusion. So the response continues for 4 months. It's a long time, and this is actually not unusual for a containment response to continue for this long. Screening was expanded to include other high-risk patients and continues until there are 2 consecutive screens with no new positives. And again, this is a standard response. Education and rounding continue to ensure appropriate infection prevention practices. And last but not least, your facility participates in a public health regional training session to educate other hospitals, long-term care facilities, transport services, and long-term acute care hospitals in your area to ensure a coordinated approach to multi-drug resistant organism control. So I hope that actually kind of helped to bring together a lot of the information that was discussed today. And so I'd like to use the remaining time for any questions that might have come up.
Here's a question. When will
the North Carolina DHHS Diseases and Conditions Reportable in North Carolina form be updated to include CRE and CORIS? The current online form shows it was last updated in 2016. So I don't have the exact date for that. I do know that in our administrative code, it is already updated. It was updated effective October. I think maybe the first week of October, if I remember correctly. So as far as the form online, I'm not sure when that will be updated, but it is official now.
There's a question about, will the slides be available? And the answer is yes. You can go to the SPICE website, and it is listed as a resource under acute care facilities. Or you can go to the SPICE website, go on the little search button and type in CRE, and you will see it listed, I believe, at the end of the list, and it does say December 2018.
I would recommend looking at those slides. We have a couple of extra slides at the end here that might be useful, including an algorithm for when to report and send isolates to the state lab.
Yeah, that's a good point, Heather. We actually have some resource slides at the end of the presentation. I think these will be of value to all of the participants here. Hey, Kathy, the form is really difficult to find on the website and I can't copy the link. Can you email that link? The link for
The
our
facility.
Oh, the interfacility transfer form? Okay, yeah, we'll make sure you get that. Okay, yeah.
And Evelyn's saying she can link to it on the SPICE website.
So does the state send CRE information to local health departments? Yes, we do. In fact, we've actually held a couple of similar webinars with local health departments, and we plan to have additional educational sessions with them. So what are current CDC isolation recommendations once an organism has been identified for just one carbapenem antibiotic?
So the recommendation is, so I think that what this is asking is if it's resistant to only one carbapenem. And the CDC case definition only requires resistance to one for it to be considered CRE. And so currently, CDC recommends for acute care hospitals to place those patients on contact precautions. So it doesn't matter if you're resistant to one or multiple carbapenems. Once it's diagnosed as a CRE, those patients need to have appropriate precautions.
So we have two more questions. The first, Katie, you might know this, I'm not sure. What type of plates are used for screening for CRE? Plate?
It's, as far as the colonization screening, if I can speak to that, so that's not a culture-based method, that's a molecular method. For if you wanted to screen within your facility, I would think that it would be something that would be enriched to promote the growth of gram negatives, but I don't have the specifics right here in front of me. CDC does have some laboratory protocols online for how to conduct that sort of screening.
And the most often is the Cepheid, which is a PCR assay that's done directly on the specimen.
Yeah.
So you're not isolating organism before you run the test.
Exactly. Okay, and one last question I want to get to. Do you have a recommendation for scripting if we decide to screen a roommate? And yes, we do. we actually have some recommendations for how to communicate with those patients. So we can definitely make that available to you as well.
Yeah, that's information we share as part of that consultation process for screening. We share our scripts and any other resources that we have that might be helpful. And one of the things that's important to mention there is that this is screening is not being done for research purposes. So all your patients definitely have the right to refuse a screen if they're not comfortable, but this is for public health intervention. So it's not an active consent process that's required. So you should answer their questions and explain to them what's happening, but it is not research, which sometimes is a confusing point.
So there's a question, are there other organisms that have inherent resistance to carbapenems that don't need isolation? Yes, that would be true. I'm having trouble coming up with an example organism. I believe Stenotrophomonas may be one that is not particularly susceptible to carbapenems. There are a few that would be inherently resistant, and so those would not require isolation necessarily. And usually your hospital will have some, or your facility will have some protocol they follow to determine who needs isolation based on either the number of antibiotic classes that particular isolate is resistant to, or if it's resistant to a certain proportion of antibiotics. So for instance, Stenotrophomonas is only treated by a few types of antibiotics. And so let's say it's only possible to treat it with 3 different classes of antibiotics. If it's resistant to 2 of those, then they would need to be on isolation by some.
Part of the reason why it's so important to talk with your labs and make sure that they're using the current CLSI breakpoints. So in that M100 document, which we linked to in the laboratory guidance that was developed in partnership with our laboratory response forum, we talk through those. So if something does have inherent resistance to carbapenem or has higher levels of resistance to carbapenem, those cut points would look different. So what MIC value is considered resistant for E. coli is lower than for Pseudomonas, for instance. And so it's really important to make sure that your lab is using those current cutoff points for those interpretations.
Yeah, and I can't emphasize that enough. So thanks for bringing that up, Heather. And I also wanted to highlight the fact that we're happy to talk through situations with you. So feel free to reach out to us. And I think on our slide that we have pulled up here, our email is listed at the very bottom, and you can reach any of us through that email address. It's nchai@dhhs.nc.gov. And I wanted to mention too, there was another question about getting a copy of this presentation. It will be available to you.
Yeah, well, there's a PDF is available on the SPICE website, and probably the easiest thing to do, go to spice.unc.edu and search CRE.
And for those of you who are still on the call, on the webinar, we certainly appreciate your time today and wanted to conduct a little bit of a post-test. So we hope that this has been extremely helpful to you. I know there was a lot of information, very fast-paced, but I hope it has made you more comfortable with the process of CRE reporting, surveillance, containment, and response. So So it looks like there's been some improvement. There are still a couple of people that are hesitant, and we realize that this will. I think it'll take many iterations of discussions around CRE reporting and surveillance to make sure that people are comfortable with the response.
Yeah, I think it's moving here. I think it was their old responses that were still there, and now people are
They're moving.
Great.
Yeah.
And I know we're just a couple minutes over, but it is really helpful if you can just stay on and answer these questions. We're going to use these to try to help figure out what additional resources or education is needed. So please just hang on with us for a few more minutes and answer these evaluation questions. And next, I can identify resources and key stakeholders related to CRE responses. Looks like there's a lot of green there.
It's encouraging.
We at least want you to know where you can go to ask. Yeah. I can describe containment strategies for CRE.
looks like we got a good amount of movement there to the green.
Okay. Still one or two that are not certain, but yeah, it looks like more people are moving over to the green. So that is encouraging. And again, I hope you're not discouraged. This is very complex information and does take a lot of will take a lot of time to, I think, thoroughly integrate it into your work processes. All right, and last, I think it's last. I'm comfortable assessing infection prevention measures to prevent CRE transmission. We have one more after this. Okay.
So not seeing a lot of movement on this one.
Okay.
I'm comfortable assessing infection prevention measures. Yeah, it's not forwarding on the app.
No, it didn't come up. Okay. Uh-oh. All right. Might not be coming up quite on the app.
So this one did.
The first two did.
Okay. So it looks like the first two came up, but maybe.
Oh, we've moved
Yeah.
again.
Mhm.
You can go back if you want.
Try to move it forward again and see if it goes.
Nope, and that's the last one. Okay. Yeah, there were people moving. All right.
There'll also be a recording of the webinar that will be made available on the SPICE website.
So I think that was the last question, and we thank all of you who attended today and who stayed on until the very last end and answered the questions for us.
I see a question here about a long-term care patient with CRE and about the cost of moving to a single patient room or whether you have patients stay in their rooms. And I think that the cost and billing is a separate issue, but from a public health perspective, whenever possible, we certainly recommend a private room in a long-term care facility. And when that's not possible, then we look at roommates that are at lower risk for transmission. So if you have another CRE positive patient, it would be appropriate for them to be a roommate. And then as sort of a last resort, we would have a patient that doesn't have a lot of open wounds or devices, that is fairly mobile and doesn't need a lot of assistance with daily living, since they would be less likely to acquire CRE.
And so I see one last question here. What type of precautions for long-term care? And again, from a public health perspective, especially for a CPCRE and one that's a tier 1 or tier 2, we do recommend contact precautions. But we acknowledge that there are definitely variances within long-term care settings for how those are applied. But particularly for a carbapenemase producing CRE, we do recommend contact precautions for a long-term care setting. And we anticipate working through many of those challenges with you all throughout this response.
And if you look at the CDC guidelines, they talk about kind of an individual patient level risk assessment for transmission in long-term care. And so we work very closely on a case-by-case basis with those facilities to make sure appropriate precautions are in place.
And we realize there's some complications there on your side that make that difficult, and so we're happy to talk through with anybody who has questions.
Well, thank you all for tuning in for this webinar. Again, the PDF slides and a recording of the webinar will be available on the SPICE website. Thank you.